talk about obstructive sleep apnea and its effect on the hypertension. As you know, there is a criteria for obstructive sleep apnea. There is many sleep apnea. There is central sleep apnea and other of sleep apnea, but here we will talk about obstructive sleep apnea, which is the most common related with the breath disorder. And it is a criteria is repeated apnea and resuming of a breath, and it has many systemic complications. One of its complication is cardiovascular complication, and from cardiovascular complication we will talk about hypertension. 25% of it is common in 25% of male, and 10% in the women. And if it is of different age group, even in children can occur. There is many anatomical abnormalities in the body associated with increased body weight. So there will be obstruction of upper airway. That means there will be, during sleep, there will be a pressure of the posterior of the tongue and the uvula in the epiglottis, so it will obstruct the upper airway, and the obstruction is gradual till it will cause complete cessation of a breath, and then the patient will awaken horrified, choking, with breathing rapidly, then return to normal and re-sleep, and after re-sleep this will reoccur again, so it will continue many times at sleep, and so the patient will has many attacks of apnea and awareness of from sleep, so the patient will has dissociated from normal sleep pattern, and that will has its complications and many clinical implication. The main symptom of obstructive sleep apnea is snoring. So snoring is first cardinal symptom of OSAS, which is mean obstructive sleep apnea syndrome. So the patient will has restless sleep, and there will be a frequent awaking from sleep, and that means that he lack of sleep at the night, so he has daytime sleep time, and that will lead to impairment of cognitive function and their loss of concentration, and so the patient will lose its memory, and the patient all the day is irritable. And there will be change in the sleep behavior, normal sleep behavior at night, so he will sleep in hyperextended neck or sleep in the hyperextended position, and so the patient will has excessive night sweat. And this is the main symptom, is at the top, snoring. One of first symptoms to be noticed in obstructive sleep apnea is to ask, is he snoring? If he is yes, this is put in suspicion in the first criteria of obstructive sleep apnea. And then the other symptoms, which is recurrent apneas at night. How we will diagnose OSAS? It is by a sleep specialist evaluation that her teamwork should be done by a sleep specialist, and to study the overnight sleep by body sonogram. And there another, if it is high suspicion, we can do even home sleep test. And it is significantly diagnosed, but should exclude another condition which impair sleep, like chronic heart failure and other CNS diseases which lead to central sleep apnea. This is Police monogram. Here we will study, will sense the nose for airflow, and we will measure eye movement and abdominothoracic movement, which is change from physiology, and oxygen saturation. And then we will study all data should be collected for studying by Police monogram. How we will treat sleep apnea syndrome? There is first with conservative measure. That means weight reduction, which is cornerstone of our management. Avoid alcohol. That alcohol affects sleep pattern and lead to obstructive sleep apnea, one as a secondary cause. There is ENT problem like nasal obstruction, sinuses, which should be treated to overcome snoring. And avoid sleep in his back. That means we advise patient to side sleep. This is conservative behavioral therapy of the patient. Then, if it is failed, we will go for mechanical treatment by either continuous positive airway pressure or by dual positive airway pressure, and there is automated CPAP or BiPAP, and then other than automated, which is far away use of tele CPAP and BiPAP, which is a new technique used for a breath. This is mandibular advancement device, which is put to bring the mandible forward that prevent the tongue and the uvula to obstruct the upper airway. This is by hypoglossal nerve stimulus. This hypoglossal nerve stimulus, which put at night, which made the neurotransmitter to stimulate hypoglossal nerve and prevent relaxation of tongue during sleep, so obstruct upper airway. If all are failed, we will go for surgery. Here, surgery by somenoplasty, tonsillectomy, or uvulopalatopharyngoplasty, mandibular and maxillary advancement surgery, and nasal surgery. So all the surgeries will be in the upper respiratory system to correct the anatomical condition to improve sleep. What are the relation of OSAS and hypertension? As long as there is apnea and then mechanical stimulation, there will be a stimulation of neurohormonal factors and stimulation of sympathetic nervous system, and that will lead to stimulation of renin, angiotensin, aldosterone system, so will cause increased catecholamine. That means increase in heart rate, stressor of myocardium, vasoconstriction, and so elevation of blood pressure, and that blood pressure will lead to left ventricular hypertrophy, cardiac ischemia, and then consequences of heart failure. And these all have been registered and noticed in OSAS syndrome. That caused by sudden drop in oxygen during apnea, and that lead to neurohormonal side effect and elevation of blood pressure. This is the pathophysiology. And this is the pathophysiological cycles of relation of OSAS with hypertension and other cardiovascular disease. Now, interdependence between OSAS and hypertension. Half of all patients with sleep apnea are hypertensive. And there is a significant level of resistant hypertension associated with patients with OSAS. There is interaction between OSAS severity and hypertension. there is a grading of OSAs, mild, moderate, severe. So as long as an increase in the grading of OSAs, an increase in severity of hypertension, and so other complications of cardiovascular disease. There is nocturnal hypertension, which is characteristic to OSAs. Once patient has nocturnal hypertension, this we should put in mind that the patient might have OSAs. Systolic and diastolic hypertension with relation with obstructive sleep apnea. There is isolated diastolic hypertension, strong relation of diastolic hypertension with obstructive sleep apnea. And there is strong association between incidence of combined systolic and diastolic hypertension, especially in young patients with obstructive sleep apnea. And there is no significance of systolic hypertension with obstructive sleep apnea. So obstructive sleep apnea either associated with diastolic hypertension or combined systolic and diastolic hypertension. Now, there is in obstructive sleep apnea and hypertension, there is change in the structure of the cardiovascular system. That means there is impaired right ventricular systolic and diastolic function. So that means right ventricular hypertrophy, pulmonary hypertension, and that associated with cardiac arrhythmia of right ventricle origin. And there is left ventricular systolic function impairment, and there is right ventricular ischemia, and that means there is defective performance of right ventricular function associated with obstructive sleep apnea. And these improved with improvement of OSAs. As improvement in OSAs, there is improvement in systolic left and right side of the heart. Management is a treatment of a primary disease of obstructive sleep apnea, and the treatment of hypertension will depend according to the condition of the patient and to choice of type of drugs. Thank you.